doctor working in the NHS in the UK, and from November last year I spent 5 months working at an Ebola treatment centre in western area Sierra Leone. My role involved caring for patients with Ebola virus disease, and it's through that work that I realised an appreciation for a desperate need for palliative care in these patients. And I don't think it's a topic that's really discussed. There's lots of discussion around novel therapies, potential vaccines, supportive care, but actually no one's talking about care of the dying patient. Okay, so just a really quick recap around the background of Ebola. It's a single-stranded RNA filovirus, of which there's 5 known species, 4 of which cause diseases in humans. The current West African outbreak is caused by a strain of Zaire Ebola virus. It's a zoonotic virus that's thought to have an animal reservoir in the fruit bat, and it's spread to humans through the butchering or consumption of infected bushmeat. So that's either the fruit bat or non-human primates infected by the fruit bat. Human-to-human spread is through direct contact with infected bodily fluids, and this makes it quite a tragic disease in that it affects carers and healthcare workers predominantly, as they're in the front line dealing with infected patients. Press the wrong button. So again, just a quick recap over the current West African outbreak. It was recognised by the WHO in March 2014, and by August of the same year it was declared a health emergency. It's the largest the world has ever seen, and cases have been reported in 10 countries, with the 3 worst affected countries of Sierra Leone, Guinea and Liberia still reporting cases at the moment. The epidemic in West Africa is much worse than previous epidemics that have been confined to sub-Saharan Africa and Central Africa. And this is probably due to the poor public health infrastructure in these countries, really high population density, and perhaps a delayed international response to the epidemic. So the signs and symptoms of Ebola virus disease are wide-ranging and progressive. Upon entry to the body, the Ebola virus has a period of asymptomatic viral replication, denoted by the incubation period of 2 to 21 days. It targets dendritic cells and macrophages, causing a dysregulation of the host immunity. Spreads through the lymphatics to target organs of the liver, spleen and kidneys, and the resulting necrosis within these organs causes a systemic inflammatory response along with a macrophage infection. And this gives you the symptoms of a general viral illness of fever, myalgia, fatigue, arthralgia. The resultant systemic inflammatory response is thought to cause the gastrointestinal symptoms that we see of diarrhea and vomiting, and patients with gastrointestinal involvement can output around 5 litres of diarrhea and emesis a day. Again, the systemic inflammatory response leads to increased vascular permeability, and with rapid replication, high viral titers, and in a patient with this dysregulated immune system, it can very quickly become an overwhelming disease state, causing shock, end organ damage, hemorrhage, and ultimately death. So Kerry Town is an Ebola treatment centre where I was working. It opened in 2014 in the middle of the epidemic in the western area of Sierra Leone. It's an 80-bed facility run by Save the Children. It shared a site with a 20-bed facility for healthcare workers infected with Ebola through their work, and that was run by Tutu Field Hospital of the British Defence Medical Services. Also, due to recent advances in portable laboratory technology, we had on-site laboratory facilities run by Public Health England. We admitted patients that already had Ebola virus disease confirmed in holding centres, and on admission we repeated that PCR test, did malarial RGTs, and took haematology and biochemistry samples as standards, which is something that's brand new for an Ebola outbreak. It means because we had the on-site laboratory, we had a blood work turnaround time of a few hours rather than a few days seen at many other centres. On admission, we also clinically staged patients. So stage 1 denoting mild or early disease, so that fever and arthralgia. Stage 2 was for those patients who had gastrointestinal involvement, and stage 3 was reserved for those patients that had late and complicated disease with evidence of shock or hemorrhage. We could offer supportive treatment, including intravenous fluids and symptom relief, as well as antibiotics and antimalarials as required. So why is palliative care so important? This slide just is a bit of a description about a representative cohort of patients. We collected the demographic data of patients admitted over 1 month as part of a wider study that Luke's going to talk to you about next. But I think this slide really just shows us we had a young patient cohort of an average age of 26 years, a third of whom would die, on average, less than 4 days after we admitted them, and 20% of those patients who died were children. We had some clues as to those patients who were more likely to die, in that those admitted with a higher disease stage on admission or had a low cycle time denoting high viral load were more likely to die. So 2/3 of patients in stage 3, but their outcome was ultimately death. Palliative care is defined by the World Health Organization, as you see here, and it's a term that denotes caring for patients with life-threatening illness and pays special attention to symptom control, as well as spiritual, psychological and emotional support for patients and families, and also after-death care. What does this mean in an Ebola setting? It means quick and accurate diagnosis of dying. You know, most of our patients, we had less than 4 days to recognise that they were a patient that was likely to die, but we didn't want to get it wrong in such a young patient cohort. Symptom relief had to be effective. I'll discuss later the interrupted ward rounds that we could do. You had to deliver a symptom relief and know that it was going to work. And as well, delivering psychological, emotional and spiritual support to a patient group that were very scared, very unsupported in difficult situations. And then delivering this bereavement support to families after the death of their patients. So these are the challenges that we faced, and most of them were related to the necessary infection control precautions. So as you can see here, this is a colleague of mine, Stephen, working at the treatment centre, and he's wearing protective equipment, revealing a small sliver of skin around his eyes, and that's it. Obviously, this creates huge barriers to both non-verbal and verbal communication with patients. Also, in a West African climate, it's very, very hot, very humid, and most workers can tolerate about 45 minutes to an hour in this kit before they start to feel unwell. They've lost too much fluid through sweat, too hot, difficulty breathing, and they need to go to decontamination. So this significantly limits your time with patients. If you can tolerate that for an hour and you've got 60 patients, that's a minute per patient. And again, this is linked into this idea. We had non-continuous presence of healthcare workers on the ward. So after decontamination, healthcare workers took a few hours to rehydrate, get feeling better again before they could go in and see patients. And the fact that patients had to be isolated from their families, from the community in the centre, led to this quite reasonable fear from patients of dying alone in an Ebola treatment centre away from their families. As well, families were unable to come in and visit, and in most cases, if the patient was unwell, they were unable to see their relative after they were admitted to the centre. And this can breed a bit of an ethos of mistrust of the centre. you admit a patient, some come out, some alive, some don't, and no one quite knows what has gone on inside. And that was something that we needed to address. And this, yes, like I said, this leaves patients quite unsupported. Their normal support network is not there when they need them. So how did we overcome this? We wrote our names on our personal protective equipment. We tried to keep teams staying on the same ward, caring for patients day after day, improving the patient relationship. Hopefully they could recognise you just from that small bit of skin or your accent or your name. We increased staffing levels, meaning that bigger teams could go in, spend longer time with patients, and these teams then worked in shifts. So as one team were cycling out, another team were going in, creating a much more continuous healthcare worker presence on the ward. We employed a clinical psychologist who addressed many of the patients' concerns and fears. And she was trained to go into the red zone and could talk to patients if that was something that they wanted. We built a patient viewing area, so where when patients were well enough, if they were well enough, they could see their family and talk through the fence. And we had open access visiting hours organised through the patient care team that were a really important link in open communication lines between families and trying to break down this idea of mistrust about what we were trying to do in the centre. Again, other issues we faced around the continuing and in fact increasing infectivity of patients after death. Patients who die from Ebola are very, very infective, and this put restrictions on traditional burial practices, which in that part of the world involve washing the body after death, touching the body after death as mark of respect. And as well, patients were double body bagged for protection of the workers who had to deal with the body, and this can lead again to mistrust from the families about exactly who is in that bag and if it is indeed their relative. Medication storage was a bit of a problem as well. Most of the drugs that we like to give for symptom control, such as morphine, diazepam, IV paracetamol, all stored in glass vials, and opening them in isolation zone creates a real risk of PPE breach and even cuts to the skin. So we made a decision to store all of those outside of the isolation zone, meaning that they either needed to be made up preemptively before you went in to see any patients, leading to waste, or you needed to radio out for someone to make it up while you were with the patient. Again, if you've got a minute per patient and you spent 2 minutes waiting for some diazepam to come in, you can see the problem that this creates. Again, necessary controls around medications, such as opioids, mean that they were kept under lock and key outside of the isolation zone. The key was in another part of the centre that needed signing out, creating delays again in delivery of symptom control. And a delayed diagnosis of dying. So we were dealing with a disease that was new to the area. Most of the people caring for patients with Ebola had never done so before. What this meant in holding centres is that patients weren't recognised to be terminally unwell. We saw patients transferred from holding centres to the centre who died in the ambulance or died minutes after arrival. And what that meant in our centre is actually we persisted to carry out life-saving procedures, repeated attempts at access, intravenous access or intraosseous access, minutes or hours before patients died. So again, we tackled this by offering a bereavement support service for families and got body bags with viewing panels so that the families could see that it was indeed their loved one, and that this really helped with the grieving process. We bought medications in plastic containers. Sounds really simple, but it wasn't something anyone had thought of. We started preemptively making up control medications and all the medications we need before we went in, feeling that it was worth wasting some medications for the overall benefit of the patient. We employed the senior clinician in a role of experience to make decisions about palliation of patients, and all very unwell patients were seen by that doctor who could make these decisions. And obviously, as time went by, we all developed clinical experience in dealing with patients with Ebola. So, in conclusion, the lessons we learned and lessons that should be taken home for anyone who's thinking of setting up an Ebola treatment centre. Palliative care should be a fundamental part of any response to an outbreak of an incurable disease. Palliative care delivery in an Ebola setting is and will remain very challenging, and staffing levels at a treatment centre should allow for this almost continuous cycling of clinicians through isolation wards if you want to deliver adequate palliative care. Medications should be stored in plastic containers so that they're instantly accessible, and real attention needs to be made to the emotional, psychological and spiritual support for patients. It really was lacking, and it's something that we need to try harder to do. Thank you very much. Any questions?
Thank you. Very excellent presentation about those who are really working in the fields with the boots and in the soil. Are there any questions? Then I have two questions. Yes, please.
What I don't understand is why the healthcare providers have to be effective in all that costume, especially the face. Why it has to be covered? Because I thought the contamination is only by the fluid exchange of fluid contact.
Mm-hmm.
So why do you need to cover your face?
So your face has many openings to the outside world. Splashes of infected fluid getting into your mouth is infected fluid coming in direct contact with your fluid. So eyes, nose, mouth, although it's not an airborne disease, you can get infected that way.
It's a very humid environment and you have a lot of droplets in the air, and that is the risk.
See, but I thought it's not by droplets that it's infecting. I think direct contact with fluids.
Mm-hmm.
Yesterday, I presented on one of my slides that experimentally, Western Ebola, which has not been shown to be human pathogen, have been shown to infect through aerosolization. So, I mean, chances are, if splashes, if you're handling a patient very closely and splashes come onto you, you can get infected.
And the splash is now a droplet of fluid.
Yeah, I think even without this idea of aerosolization or droplet spread, all it takes is for you to have a cut in your mouth, a child with sweat containing Ebola virus to reach up and grab you, and you've then got a significant risk of infection.
No, it's only prudent to have those short precautions. My question was related to what our chief presented yesterday, the PPE. You know, so the healthcare worker returning from the area back to U.S., they were probably exposed during removing those.
Undressing.
Yeah.
Mm.
So, what are the procedures being implemented to protect the healthcare workers so that they properly remove the gowns? Not get it. Is there any SOPs in place?
Certainly our centre had an SOP on it that was constantly revised with any time there was new evidence, but the evidence is quite limited. Personally, I went through many times into the red zone and decontaminated in the way that I had been shown, and fully educated in, and many of the NHS workers in this country were educated before they went in country, and then again we did repeated educations in decontamination, and if you followed the protocol, I think you were kept safe.
Further question, yes?
I have an ethical question. You know that precautions are so costly, they're very expensive. In countries that those precautions are not available for the health staff, if he has the right, he or she has the right to refuse to provide the health care.
yes, it's very, very tricky, and I think that's what had happened before people from the international community with these precautions arrived in Sierra Leone. Healthcare providers in that country weren't providing any medical care. Certainly, the only hospital I think I know of in Sierra Leone that was still operating was in Freetown, and that was because King's College were in there providing an isolation service that could deal with Ebola cases while healthcare workers could treat other diseases. But I can totally relate to the sort of overwhelming fear of seeing anyone with a fever in that situation. And yes, and I think in that situation, lots and lots of healthcare workers had refused. I mean, many of them knew numerous colleagues that had died from trying to care for patients with Ebola already by the time we arrived.
Thank you.
Okay.
Thank you again for this excellent presentation. And I have also for you the certificate